I welcome you all for today's webinar on updates on HCC. With immense pleasure, I would like to invite Dr. Anand V. Kulkarni, sir. He is a senior consultant of hepatology, liver transplantation, and multi-organ transplants at AIG Hospital, Hyderabad, for the welcome and introductory note. It's over to you, sir.
Thank you so much. At that outset, I would like to thank Nishant and his team for organizing this event. We have a great event on HCC today. We'll have updates on epidemiology, the pathogenesis, the myths and facts, followed by use of immunotherapy in vessel bleeding and a case presentation. We have a great line of speakers. The first speaker will be Dr. Mithun Sharma, who is the Director of Hepatology. And actually, I'm sitting in his room. And we have first, he'll be talking about epidemiology and screening of HCC. He'll walk through us and then followed by other speakers. Dr. Mithun Sharma to start, please.
Yeah, thank you. So can I get my slides to share? Yeah, got it. So slides are visible, I presume, right?
Yes, sir, visible.
Yeah, so thank you, Dr. Anand and everyone for inviting me to give this talk on screening and surveillance and epidemiology of hepatocellular carcinoma. So first of all, this is the outline of our discussion. Is we'll talk a bit about epidemiology and then about surveillance and what to do to diagnose hepatocellular carcinoma early. So we all know, as regards to epidemiology, it is the 5th most common cause of cancer and the 2nd most common cause of cancer-related death worldwide. So there are around 8,54,000 new cases and around 8,10,000 deaths per year, which accounts to around 7% of all the cancers. 90% of all the liver cancers are hepatocellular carcinoma. The peak incidence is at 70 years of age, but we are more and more seeing younger patients being diagnosed with HCC. Earlier, it was younger in the Chinese and African blacks. Japanese are a decade later because their most common cause was Hep C related. It is more common in males when compared to females. However, what is the most alarming thing is that the current new cases, more than 50% cases, are coming from East Asia. And there is a rise in the overall incidence because of possibly the increase in NAFL or MASL, what we call now, except in Japan, where there is a descending trend, possibly because of the direct-acting antivirals that are available for the treatment of hepatitis C. So when we talk about the epidemiology of HCC, we divide it into zones of very high incidence, moderately high incidence, intermediate incidence, and low incidence based on what is the standardized incidence per 1 lakh population. If it is greater than 20, we label it as a zone of high incidence. Between 11 to 20, it is moderately high. If it is below 5, it is low incidence. And between 5 to 10, it is called a zone of intermediate incidence. So this brings to the question, are we justified in surveillance of our patients to detect early HCC? So this is how surveillance justification is made. It is presumed that a surveillance program is considered to be effective. It can increase our longevity by around 100 days, which obviously is true in case of HCC. And according to the US standard, if the cost is less than $50,000 per year of life gained, it is considered as cost effective, whereas the Europeans decide it based on the incidence of the disease. If it is greater than 1.5% per year, it warrants a surveillance irrespective of the cause. So does surveillance program help for hepatocellular carcinoma detection? So these are the 2 studies. This was the initial randomized control trial where they compared surveillance ultrasound and alpha-fetoprotein done every 6 monthly versus no surveillance. This was done in around 18,000 patients between 35 to 60 years of 59 years of age in urban Shanghai with or current or prior Hep B infection, regardless of the presence of cirrhosis. Though the adherence to the program was very minimal, which was around 55%, yet it was seen that the mortality decreased by 37% in the surveillance arm, thereby favoring surveillance program. There was another study which tried to use only alpha-fetoprotein, but that was not found to be significant in patients with Hep B. There are many other studies after that which have shown that benefits of regular ultrasound in detecting early HCCs in patients who are having high risk of the disease. Now, who undergoes surveillance? So these are the different societies, the EASL, the AASLD, and the Asia Pacific Society. So nobody has a doubt that in patients of Hep B, Hep C, alcohol, or NAFL, child A and child B cirrhotics, they should all be undergoing surveillance. But the EASL and the AASLD believes that if the patient in child C and doesn't have a transplant in hand, because the other modalities of treatment are not applicable in patients with child C, a surveillance may not be effective because the cost of possibly ultrasound screening in those countries are very high. But the Asia Pacific believes that yes, even then we should screen these patients because some of the decompensations or the patients converting to Hep C, converting to child C are because of the disease or the cancer itself. Non-cirrhotic patients, hepatitis B, if it's an Asian male or above 40 or a female above 50, or if there is a family history of HCC, there are strong recommendations to keep this under surveillance, where the EASL feels that there is very uncertain recommendations in following up patients of fatty liver without fibrosis. However, the APASL believes that we should be screening the patients who are at high risk of HCC. We can use scoring system like the PAGE-B score for Hep B, where we include platelet count, age, and gender. A score of more than 18 indicates high risk, which means that there is a 17% risk of HCC at year 5, while if it's less than 9, the risk is very low at 5 years, and we may not be screening these patients. So to summarize, the different guidelines believe that in patients of cirrhosis, child A, child B should be screened. APASL believe child C can be screened. There is always this recommendation debate in non-cirrhotic Hep B, Hep C, and NAFL with fibrosis, but we in our clinical practice do tend to put all of them under surveillance because an ultrasound doesn't cost much in Indian settings. So this is what the AASLD guideline recommends, that we should not only look into liver-related factors, we should look into other factors also. For example, if there is an associated smoking and alcohol, it possibly will increase the risk of HCC by 9 times. So I would try to screen even a Hep B carrier with or without cirrhosis who has a history of alcohol and smoking, because they have an increased risk of development of HCC. How do we screen them? The EASL believes we should do a 6-monthly ultrasound only, which they recently modified again. And the AASLD and the APASL believes that it should be an ultrasound and alpha-fetoprotein, which is definitely complementary to each other. When we use ultrasound, we should all keep in mind that the false positive rate are more with ultrasound. But what is very important is that 20% of ultrasounds that are done in real-time clinical practice are actually classified as inadequate for surveillance. How do we interpret a lesion on ultrasound? If there is no focal abnormalities or there are definitely benign lesion like cyst, we consider this as a negative sound screening. However, if the lesion is greater than 1 centimeter or equal to 1 centimeter, we consider them as positive, or that the risk of HCC is high. If the lesion is less than 1 centimeter that are not definitely looking benign, these are considered to be non-diagnostic. So a meta-analysis of 17 studies showed that the pool sensitivity of 94%, as well as similar specificity, while using ultrasound as a surveillance marker. We use ultrasound because of the absence of any risk factor. It is non-invasive, it is well accepted by the patient, cost-effective. But the disadvantage is that it may not be able to identify some lesions in cirrhosis because many of them are isoechoic, and it depends on the expertise of the operator, how much he is interested and is seeing the liver properly, and obviously the quality of the machine. The next biomarker that we use is alpha-fetoprotein. It is considered more of a diagnostic tool than a surveillance tool. Because why is it having a suboptimal performance as a suboptimal tool, as a diagnostic tool? It is because there are fluctuating levels in Hep B and Hep C. So, and only a small proportion of early HCC have a raised alpha-fetoprotein. It also depends on what cutoff we are taking. If we take an alpha-fetoprotein cutoff of greater than 20, the sensitivity is 60% and a specificity of 90%. But if we take a higher cutoff like of 200, it becomes more specific, but the sensitivity falls to 22%. So a longitudinal change in the alpha-fetoprotein may be more sensitive and specific. This table summarizes how different values of alpha-fetoprotein, as the value increases, the sensitivity decreases and the specificity increases. Can we combine alpha-fetoprotein with ultrasound, which we are really doing? Yes, we can do it. They can detect an additional 6 to 8% of cases, but also it leads to around 7.4% of false positive rate. So it leads to 80% increase in cost for every small HCC diagnosed. So therefore, alpha-fetoprotein is still considered as an inadequate screening tool for detection of hepatocellular carcinoma. There are other markers like DCP and alpha-fetoprotein L3 fractions. So DCP is more associated with a tumor invasions and advanced tumor, and it's unlikely an early marker. There is a proposed model, which is the Gallard model, which includes alpha-fetoprotein L3, DCP, age, and gender. If you see here in early HCC, the sensitivity is pretty good, but still not able to identify very early HCCs. A recent study from the same group has showed more effective results when they are compared with the initial studies. Can we do a CT or an MRI? Many of us have a habit of doing a CT at the baseline. CT definitely has a radiation risk, and MRI, the cost is high, but there are some exceptions. Patients on the transplant waiting list where CT and MRIs are required, patients who are obese or who have a chest wall deformity, which are limiting the proper examination by ultrasound, are the ones where we can do a CT and MRI. When we compare MRI with ultrasound, it is showed that MRI has a lower false positive rate, but yes, MRI will lead to a lot of increase in cost. Now, coming to how frequently do we monitor these patients? The ideal interval depends on the mean doubling time of HCC and the tumor incidence in target population. Most guideline recommends a 6-monthly interval, but guidelines like from the Japan says it's a 3-monthly interval. There are randomized controlled studies between 3 months and 6 months. They fail to identify any difference. However, if we compare 6 months to 12 months, definitely the 6 months is better than 12-monthly survival, because the sensitivity falls from 70% at 6 months to 50% at 12 months. What I believe is more important is the recall policy. When we find a nodule of less than 1 centimeter, we should be able to convince the patient to closely follow up every 4 monthly for 1 year, and then every 6 monthly thereafter. This is what the EASL believes. The American societies are more stringent on this. They say follow these patients up every 3 monthly. On the other hand, any nodule in a cirrhotic background which is greater than 1 centimeter, we would definitely want further investigation, be it a CT or do it an MRI or even do a biopsy in these cases. So the time would come in the future possibly where one site of it may not fit all in the screening strategy. Patients with cirrhosis or hepatitis B, we can screen them. With no cirrhosis, we may avoid screening them. Then we can use one of the HCC calculators, and based on that, we can classify them into high risk, medium risk, and low risk, and have a screening strategy 1 or a screening strategy 2 or a screening strategy 3 based on what the risk factor is. So, for example, for a high risk patient, we may try doing an abbreviated MRI. For medium risk, we can do an ultrasound or biomarkers. For low risk patient, maybe a biomarker panels, and very low risk, maybe no screening. But these are all what are suggestions, but these are not yet implicated in guidelines. There are novel biomarkers for HCC screening. These are liquid biopsies, like the Fujifilm have the Waco panel or the Gallet system, or we can check for circulating free DNA. But none of these have actually been able to detect hepatocellular carcinoma at a very early stage. What is possibly most interesting is the abbreviated MRI, where we take the MRI sequences relevant to hepatocellular carcinoma. The T1 axial contrast phases are seen, and the sensitivity is found to be almost similar to a normal triphasic MRI. It is safer, non-invasive, non-radiation, and possibly will be cost-effective, as well as time-saving for the radiology department if they are screening a huge number of patients. So with this, I would suggest that every patient of cirrhosis of liver needs a screening for liver cancer. If a patient is in follow-up and we miss early HCCs, it is not something which we should be happy about. And treating the disease or finding the disease at the early stage and doing a risk-based screening possibly will help us identify more and more cases and make them cost-effective. And because we also have to keep in mind the moment we see a small lesion and we do a lot of investigations, we are giving a lot of anxiety to the patient because they don't know when this will go into an HCC. So it should be a balance between the cost effectiveness, not causing harm to the patient, and also being able to detect early cases. With this, I thank you again for giving me this opportunity. We'll take up any questions if there are any. Thank you so much.
If there is no question, we will move forward. For the next talk, I would like to invite Dr. Santosh Kumar Chillapuram. He is a consultant, medical oncology and bone marrow transplant at Star Hospital, Hyderabad. He will give his talk on role of immunotherapy in HCC. It's over to you, sir.
Thank you very much. Thank you very much, Dr. Anand sir, for inviting me for this symposium. It was pleasure listening to Dr. Mithun sir, especially the various guidelines that say what test to screen and when to screen. Similarly, I have a very important topic, that is what is the role of immunotherapy in case of hepatocellular carcinoma. So I just share my screen. So, understanding wise, liver is an important organ located in the junction where it is exposed to a lot of GI bacteria, toxins, endotoxins, and all. If the immune system of liver is very, very robust, there would be a lot of reactions to a lot of things. So, the nature has poised the liver as a balance between aggressive immunity and low immunity. So, that is what we call an immunotolerant environment. So this immunotolerant environment is exploited by the hepatocellular cancer, where our immune system fails to recognize this, as a result of which stealthily the cancer cells grow. So this principle is seen in a lot of research papers, and they saw that this immunotolerant environment, once we break up by using immunotherapy, our own immune system might fight against cancer. So the various immunotherapy approaches in case of treating hepatocellular cancer are different. Predominantly, we concentrate or keep our discussion to predominantly this antibody-based treatment, where we give in the form of immune checkpoint inhibitors against PD-1, PD-L1, CTLA, and there are upcoming bispecific antibody against the target known as EpCAM and CD3. This bispecific bring the cancer cell and also the immune cell together. So this is the strategy. And also antibody drug conjugates are in the phase 1 trials. Of course, in hepatitis B, we use interferons previously. Similarly, the role of interleukin-2 pegylated interferon was tried, but this was a failed strategy. There is a lot of research going on to this field of using of dendritic cell vaccine and recombinant protein vaccine and oncolytic viruses as a part of immunotherapy approach to hepatocellular cancer. There is a recent phase 1 trial and early preclinical studies involving the chimeric antigen receptor T cell which showed promise. The problem is identification of a specific antigen that is restricted to the liver. So among the various immunotherapy approaches that we have discussed, the advanced stage clinical trials and in the real world, we started using this immune checkpoint inhibitors. But in years coming, we have a lot of potential in especially cancer vaccines and also chimeric antigen receptor T cells. So this everybody knows. Just to emphasize, there are two pathways, the CTLA pathway and the PDL1 pathway we exploit. The CTLA pathway is the tremelimumab based, and the other thing is the durvalumab and atezolizumab, which exploit the PDL1 pathway. This reverses the T cell exhaustion that is normally present in an immunotolerant environment. And also this immunosuppression by the CTLA4 is broken by the durvalumab and tremelimumab, especially the tremelimumab. Durvalumab acts by PDL1 axis. So also this is the thing that I was telling is the chimeric antigen receptor T cells, where we take the T cells and we engineer the T cell receptor and it gets activated by some of the specific antigens that are peculiar to hepatocellular cancer. So far, we have failed to identify, but few of the potential markers that are specific to hepatocellular cancer that were identified were AFP, glypican, or melanocyte-associated protein, and NY-ESO. These are all the clinical trials that are involving the chimeric antigen, which, if proven in a phase 3 trial, would be a game changer and provide long-term cures in case of advanced hepatocellular cancer. So to start with, what is the role of immunotherapy in an advanced metastatic hepatocellular cancer? After success of immunotherapy in this setting, immunotherapy started moving in the upfront setting. That is, in the intermediate stage where we use locoregional therapy, whether we can combine immunotherapy, and also the clinical trials are moving to the early stage HCC where we can we use the immunotherapy after surgery, that is resection of a small nodule, that is BCLC-A and all, so that the tumor will not come again. Or can the immunotherapy be used before surgery? So the neoadjuvant strategy, that is high risk early stage HCC, this is the field involving. This is how a classic clinical trials in oncology move. First, they establish their success in an advanced stage 4 metastatic HCC. Then they move into the curative and also in the early stage as a neoadjuvant or adjuvant kind of strategy. We will move to the first aspect, that is immunotherapy in advanced metastatic HCC. That is BCLC is known to this august audience. So especially those HCC which are advanced, which have VP4 kind of major portal venous invasion, and also extrahepatic spread. So this we employ systemic therapy traditionally, but this systemic therapy is moving much beyond in the early stages. Previously, it was considered this BCLC Barcelona classification is a watershed or watertight compartments, but it is a fluid compartment. With downgrading strategy using more aggressively, we can employ more curative setting even in advanced or BCLCC, HCC also. So this is a changing concept over past 3-4 decades where we can even give a curative treatment in an advanced stage HCC where the previous survival was limited to less than 1 year. So what are the options in this advanced HCC? We have two kind of options, the immunotherapy and the non-immunotherapy based option. We have two options for immunotherapy based options, atezolizumab, durvalumab, and tremelimumab. How do we choose? Let's discuss in the clinical trial. Those patients, if it's not feasible, then using of the TKI with lenvatinib and sorafenib. After progression, we have ramucirumab, regorafenib, and cabozantinib. And of course, there are clinical trials for CAR T cells whenever they progress beyond this. This is the trial that has proven its role in the management of advanced HCC. Most of the people might have seen this trial multiple times. I would tell one or two things. The thing is, the dose of bevacizumab is 15 mg per kg. That is once in every 3 weeks. In classic oncology, we use 5 to 10 mg per kg. Also, if you can see here, those patients who have eradicated esophageal-gastroduodenal varices within past 6 months were included. Of course, clinical trial includes performance status less than 1, which is sometimes difficult to find in real-world scenario. And eradicated varices is what they have included, and they have included Asian lineage also. So they have compared with sorafenib, which was then considered the standard of care. Later, lenvatinib was there. So this is the updated analysis of IM Brave, where at the 18 months landmark, almost 50% of the patient with immunotherapy are alive, and this continues to flatten over time. So this is what has shown the overall survival benefit with a hazard ratio which is impressive at 0.66, and the median overall survival close to 20 months versus 13 months with sorafenib. The original trials with sorafenib, the survival was still less. So this emphasized the more care in case of advances in case of hepatocellular carcinoma, where they have later subsequent lines of therapy. The important point to note is the overall response rate is 30%. And this is very important. Sometimes we can find very huge tumors about to rupture, how to manage those. So the response rate we can tell is 30%, and the confirmed response rate is 8%, and the disease control rate is 75%. So almost 75% of patients will have some stabilization or response with the use of atezolizumab plus bevacizumab compared to the conventional sorafenib-based treatment. The important point to note in immunotherapy is this flattening of curve towards the tail, where even after 2 years, you can see almost 40 to 50% are still alive and doing well. These are possibly the patients who would achieve long-term cure and remissions. The second point is which among these patients would do long-term. So there was a subset analysis which has showed that those patients who respond, that is, those patients who have at least a complete remission or partial remission, you can see at the landmark interval of almost 25 months, 80% of the patients are alive. So we can at least counsel the family that once we have a good response, that is complete or partial remission, then the long-term survival would be improved compared to those patients who did not respond. These are the poorest subset where even immunotherapy doesn't work, and a lot of research is required to see why these failed. Nowadays, as Sir has emphasized the evolving role of circulating tumor cells and a lot of molecules and miRNA. So maybe research is required. How do we improve the performance of these patients to those? So the other point I want to emphasize is those patients who respond with immunotherapy tend to have good long-term outcomes compared to patients who do not respond to this immunotherapy. When coming to the side effects, the bevacizumab-related side effects in the form of hypertension, proteinuria, and also immunotherapy-related side effects in the form of elevation of TSH, thyroid abnormalities, and some autoimmune side effects, where diarrhea and plantar dysesthesia was the class-specific features of sorafenib. And these are more or less tolerable. And you can see the quality of life in patients who received atezo-bev is comparatively better compared to those who received sorafenib, where they would have very problematic side effects in the form of hand-foot syndrome and diarrhea, which causes day-to-day deterioration in quality of life. The other trial that has shown potential in treatment of first line is the Himalaya trial with the STRIDE protocol. STRIDE protocol is really interesting. What they have seen is durvalumab and tremelimumab combination, when used continuously for all the doses, causes a lot of autoimmune side effects, and as a result of which causing mortality. So what they have restricted tremelimumab to 1 dose and continued durvalumab. This is called the STRIDE thing, what they call a single tremelimumab and continuous dose of durvalumab. So they have randomized to durvalumab, and sorafenib. This is the analysis, statistical analysis, if you want to see, or what they have postulated is, arm 1 versus arm 2. Arm 1 versus arm 3. That is the STRIDE protocol versus sorafenib is the what they want to see. Also, they have analyzed whether single agent durvalumab would be non-inferior to sorafenib. Here, you can see in this clinical trial, the OS and PFS. First, let's see how did the sorafenib arm. It is 13.7 months. It is same as the we have seen with the IM Brave trial. And the durvalumab, the median overall survival is 16. It is not sacrosanct or to compare two randomized controlled trials. The hazard ratio is somewhat a measure by which we can at least compare two trials. The hazard ratio in this trial is 0.78, where it was 0.66 in case of Atizo and bevacizumab. And the second point that was established is durvalumab was non-inferior to sorafenib. We don't know whether it is superior or anything. The trial is hasn't answered. And any immunotherapy trial, we see the tailing towards the end. That is, at the mark of 3 years, you can see almost 40% of patients are alive at the end of 3 years. So a lot of debate occurs which strategy to follow, the IM Brave way or the Himalayan way. There is no head-to-head comparison of the two trials. Both has shown improvement over the comparator sorafenib. If lenvatinib would have been there, we would know which is more robust molecule. I choose based on the patient profile, the varices, and how much is his hypertension control, and the long-term data of Atizo-Bev is more robust. And also Himalayan trial, we have to see more long-term outcomes, and also the immunotherapy. The Atizo-Bev has a combination of immunotherapy and vascular endothelial growth factor, that is VEGF inhibitor like bevacizumab, where day-to-day and real-world evidence is also there in that. Time will tell which will tell. But in those patients with uncontrolled hypertension and proteinuria, and those who have cardiac events or cerebrovascular accident, giving bevacizumab will be a problem. In those subsets, maybe Himalaya would supersede those of the other trial. So there were other clinical trials that tried, that is Cosmic trial, tried cabozantinib plus atezolizumab. This has failed, and the LEAP, lenvatinib and pembrolizumab, this also did not show a major improvement. So this is another trial, that is combination of nivolumab and ipilimumab, that has showed benefit in case of advanced hepatocellular cancer. So when we see the advanced setting, we have three options, that is Atizo-Bev, Durva-Tremi, or Nivo-Ipi. We do not have a randomized clinical trial to answer which is better. It depends on the patient's biological characteristics, whether he can tolerate bevacizumab or not. That is one important thing. Previously, there was an argument of viral-related HCC, non-viral-related HCC. Many meta-analyses have disproved that one is not superior over other. So also the availability and cost of all these agents also take a major thing in decision making regarding this one. Coming to the more earlier staging, that is intermediate HCC, where a lot of loco-regional therapies do come into picture. Do these loco-regional therapies, if we combine the systemic therapy, is there any benefit? They have shown whether it is improvement in the progression-free survival or the overall survival which all need. So the point that comes is whenever we use immunotherapy in an intermediate stage, is it just delays the relapse or it actually improves the overall survival? So that is where we have to understand. Sometimes the immunotherapy or the combination with bevacizumab might just delay the relapse. This is not we want. We want the ultimate long-term cure, that is overall survival. Let's see whether the clinical trials have answered that question. So there is an evidence of pooled analysis that showed use of systemic therapy will downstage, and the patient would be eligible for liver transplant even in an advanced case of this one. So this is regarding the taste. So this is what it showed. Taste unsuitable disease, there is a criteria beyond up to 7 criteria where large more than 6 or multiple we cannot give taste. These patients, this fall in the yellow subset, are the patients who respond good to taste. So this is a launch trial. This is a trial that has combined lenvatinib plus TACE as first-line treatment for advanced hepatocellular cancer, and they have analyzed the efficacy where it had showed improvement in the survival, but this study has included predominantly hepatitis B virus. Almost 87% in this trial was hepatitis B. Although it was stratified randomization, we have to really look deep into whether it has placed anything. This is Emerald-1 trial that have incorporated combination of durvalumab plus bevacizumab along with TACE, whether it improves the progression-free survival. The first arm contains durvalumab along with TACE. They give TACE and later start durvalumab more than 7 days after start. The other arm contains placebo plus TACE alone, and the other third arm contains the maintenance continuation of bevacizumab, and here there is no bevacizumab. So durvalumab plus bevacizumab, only TACE, and the combination of durvalumab as a maintenance strategy. This is what it tried. So as you can see, at 1.5 years, the PFS, there was significant improvement, and it has showed statistically significant improvement in PFS. OS reports are yet to be matured and to be available. So there is another trial that has that is I am brave kind of fashion, atezo plus bev versus TACE in intermediate HCC, and regorafenib and pembrolizumab versus TACE up to 7 years. So in this scenario, the problem is in the early stage, there is a bimodal curve in case of HCC. The early recurrence occurs at 1 to 2 years, and later recurrences occurs at 3 to 4 years kind of setting. So whether giving some treatment before the surgical approach, whether it eliminates micrometastasis is what is the concept in incorporating this one. The STORM trial that used sorafenib failed to show any benefit. So this tried after any resection or ablation in an early stage HCC, it failed to show. IMBRAVE 50 is an adjuvant atezo plus bevacizumab trial after resection or ablation of an early stage. They included few specific high-risk criteria, both in patients who undergo resection or ablation. So they have few criteria, the size more than the VP1, VP2, and more than 4 tumors. Based on these, they have included whether giving any adjuvant systemic therapy would be used. When you see the baseline characteristics, they are equally distributed between the both arms. PDL1, irrespective, IMBRAVE have proven that irrespective of PDL1, the responses are seen in case of HCC. As you can see, there is initial separation. This is what we can see, and later the both curves merge. So this implies that possibly these agents are delaying the relapses, not causing complete cure. So long-term data should be awaited. The advantage of using neoadjuvant immunotherapy is there is intact vasculature, so that the immunotherapy goes and acts, and it improves resectability by reducing the tumor burden. And one more area, after liver transplant, if the patient relapses, is there a role of immunotherapy? It is a strong no. The data that was collected, pooled data that showed almost 35 to 40% where the liver allograft rejection that occurred within a median of mean of 7 to 18 days, that is 10 days. Very early rejection. There are few lucky patients who did not relapse. So who are they? What are the molecular characteristics of them? We do not know. But this causes a lot of allograft rejection and a problematic area. So perioperative strategies, either a neoadjuvant strategy or neoadjuvant immunotherapy that passes down, and the adjuvant. These are the areas where we have to wait for the long-term overall survival to practically suggest to our patients. So as we know, adjuvant atezo plus bevacizumab is associated with improved recurrence-free survival, but overall survival is what we want. It is unknown. Neoadjuvant therapy is an area of active research, and most important is downstaging can be done in patients who are outside the transplant criteria by using a combination of systemic and loco-regional, and later we can take for transplant. And even after immunotherapy, liver transplant can be done with good success. Thank you everyone for listening to this. If we have any questions, we can take this, or else I would hand over to the next speaker. Thank you, the organizers, for giving me this opportunity.
Thank you, Dr. Santosh, sir. Anyone has any question? If there is no question, we will move forward. For the next talk, I would like to invite Dr. Soumya. She is a consultant hepatologist at AIG Hospital, Hyderabad. She will give his talk on myth and facts about immunotherapy. It's over to you, ma'am.
Am I audible?
Yes, ma'am, you are audible.
So at the outset, I would like to thank Roche for giving me this opportunity to present this topic today. And the previous speaker has very well concise and narrated and touched upon every aspect of systemic therapy in HCC. And I would like to thank Dr. Anand Kulkarni sir for providing the educational material and content for this talk. Next slide, please. So I'll be talking about myths and fallacies associated with immunotherapy. So we all now know that immunotherapy for HCC is the standard of care in advanced HCC or unresectable HCC. Both hepatology and oncological societies have recommended it as a first-line standard of care, first-line drug in as atezolizumab and bevacizumab combination, and durvalumab and tremelimumab in cases of unresectable HCC. Next slide, please. It was Dr. James P. Allison who identified CTLA-4 in the year 1994 from the University of California, USA, and Tasuku Honjo from Japan, who were jointly awarded Nobel Prize in the year of 2018 in physiology or medicine. Next slide, please. So coming to first myth, that is immune checkpoint inhibitors are only expressed by cancer cells. The fact is they are not. These are the physiological breaks that are expressed on all cells, and they are part of normal immune system. And these immune checkpoints prevent immune response against own cells. However, the cancer cells dysregulate these cells and develop immune resistance. For example, on the right-hand side, we see a tumor cell that expresses PD-L1, which binds to PD-1 receptor on the T cell, and this combination prevents antigen antibody and APC interaction between the tumor cell and T cell, and it inhibits the destruction of tumor cell. However, by blocking PD-L1 or PD-1 allows the T cells to kill the tumor cell. This is the principle of these targeted therapies or immune checkpoint inhibitors. Next slide, please. So coming to the next myth, that is immunotherapies are only used as palliative measures. So the fact is they are not. Coming to the response of immunotherapy as per RECIST and MRECIST criteria, we see that overall response rate is around 27.3% versus 11.9% with sorafenib. This is as per the IMBRAVE trial, and the disease control rate is 73%, 73.6% versus 55.3%, which is clearly significant. And we see almost 5.5% of complete response and almost 10.2% of complete response as per resistant MRECIST criteria respectively. So this indicates that they're not just used for palliative measures. Next slide, please. And the aim, and as it was already said in the previous talk, in any oncological trials, initially the effectiveness of any drug is used in advanced malignancies, used as a palliative care. And once the drug is proven effective, the indications can be extended at different clinical scenarios. For example, coming to the neoadjuvant immunotherapy. Neoadjuvant means bridge the patient to curative therapy and to achieve complete pathological response. There have been many trials which have used role of immunotherapy as in the neoadjuvant settings, especially in cases of BCLC A and B stages. However, the latest EASL guidelines or the ASLD guidelines do not recommend neoadjuvant immunotherapy routinely. However, these can be taken up in cases of prospective clinical trials. Coming to the next role, that is adjuvant immunotherapy after a curative therapy like surgical resection to prevent recurrence, in view of preventing recurrence and prolonged survival. It was already discussed in the previous section. There are multiple studies to know the effectiveness of these immunotherapies in adjuvant clinical settings. IMBRAVE 50 trial has initially shown some recurrence-free survival, better recurrence-free survival compared to placebo in adjuvant clinical settings. And even Emerald 2 trial initially showed good recurrence-free survival. However, at the end of the study, both of the trials did not fail to achieve any meaningful recurrence-free survival at the end of the trial. So at present, the guidelines do not recommend the role of adjuvant immunotherapy routinely in all cases. However, there are much more scientific evidence is needed, and more studies are welcoming in this field. Again, coming to the next myth, that is the etiology affects tumor response. So in patients with NASH-related HCC, the frequency of T regulatory cells and CD8 T cells strongly expressing CTLA4 were high. The frequency of CD8 T cells strongly expressing PDL1 was highest in patients with hepatitis B-related HCC. So the immune response to this immunotherapy was markedly different among these groups, and a correlation with the immune cell profile was observed, suggesting that development of immunotherapy based on the etiology of HCC may lead to more effective treatment outcomes. Next slide, please. So this is an article, previous slide. So this is an article published in Nature in the year 2021, where it was shown that NASH limits the anti-tumor surveillance in immunotherapy treated HCC patients. This paper studied three clinical trials separately. In all three trials, there was in fact growth or worsening of HCC among patients treated with immune checkpoint inhibitors alone, that is PD-1 or PDL1 receptor agonists. Next slide, please. However, there are some fallacies about these studies. The anti-PDL1 may not work, but the combination therapy was not addressed according to this study. And the diagnosis of pure NASH in clinical setting is difficult, and there can be always an overlap of alcohol or other diseases is common in the real life scenario. So the clinical diagnosis of NASH related HCC alone and not administering the atezolizumab combination may be disadvantageous to the patients. Therefore, it is important to initiate the treatment with atezolizumab and switch to second line therapy when it is proven to be ineffective. And the latest EASL guidelines that is released this month also stresses upon the same factor. Based on the etiology, do not differ treatment with first-line immunotherapies. And even the IMBRAVE 150 study subgroup analysis also shows that even in patients with non-viral HCC, the median survival and overall survival are much better in immunotherapy-treated groups compared to the sorafenib-treated groups. Next slide, please. So next click, please. So this is again, this is a study done by Dr. Kulkarni et al., which was published in Lancet. This is a meta-analysis which showed that the pooled progression-free survival in viral group and non-viral group are almost comparable. And sorafenib, and compared to sorafenib, systemic therapy had better PFS and OS in cases of NASH-related HCC also. Next slide, please. So there is a myth that if it is to be given only in BCLCC. So the trial included all untreated HCC. The IMBRAVE 150 trial recruited all untreated HCC, child PUG-A, and ECOG performance status less than 2. And the trial also included across different BCLC categories, that is child PUG, BCLC-A, B, C. And in all three groups, the progression-free survival and median overall survival were much better compared to the sorafenib treated group when it comes to immunotherapy treated groups. So any patient who is not eligible for locoregional therapies or surgical therapies, it still can be considered. The immunotherapy or systemic therapy with atezolizumab combination can still be considered in earlier BCLC stages also, and it need not be restricted only for the BCLCC category of patients. Next slide, please. So coming to the next myth, that is survival is very few months with systemic therapy. So this slide is taken from BCLC that was released in the year 2016, when sorafenib was the only option available. At that stage, with systemic therapy, the survival rate was almost about 10 months. Next slide, please. So this is the latest guidelines. With the advent of immunotherapy in advanced HCC, with the available second line treatment options and first line standard of care being immunotherapy with either atezolizumab combination or durvalumab combination, and second line drugs like nivolumab or ipilimumab, regorafenib, cabozantinib, multiple TKI options are there, and third line options are also available. With this, it is not just 1 month, and the survival can be extended to over 2 years, even in cases of advanced HCC and BCLCC stages. So it is a myth that the survival with immunotherapy or systemic therapy is just a few months. And there are patients who have achieved complete cure even with immunotherapies and have progressed to transplant also. Next slide, please. So it's a myth that there is no long-term survival with immunotherapy. It was already described in the previous slide also. With the available newer options of immunotherapy, the survival in advanced HCC has increased to nearly over 2 years. And coming to this, the left-hand side picture, that is picture A, which compares STRIDE combination with sorafenib. STRIDE is a single dose tremelimumab with recurring durvalumab doses. In this, we can see that almost more than 30% of patients are still alive after 36 months of overall survival also. So the longer the duration of admission, the longevity is increasing. And on the right hand side, we have a study done by Dr. Kulkarni et al., which shows that child PUG-A category of patients receiving systemic therapy had a survival of approximately 21 months. However, the survival rate reduces as the child PUG grade worsens. So child PUG grade might be a important factor in considering the patients for immunotherapy. Next slide, please. Myth is that immunotherapy cannot work in patients with high tumor burden or extrahepatic metastasis. So this table has been taken from IMBRAVE 150 database. So in this, we have patients with microvascular invasion and extrahepatic metastasis, in which the median overall survival has been shown to be 13.5 months compared to sorafenib arm, which is 6.9 months with atezolizumab group. And median PFS is much higher compared to sorafenib group, 6.5 months versus 2.8 months. So the overall response rate is 27% with atezobev group compared to 10% in sorafenib group when it comes to patients with microvascular invasion and extrahepatic metastasis, which clearly shows that immunotherapy does work in patients with high tumor burden and extrahepatic metastasis when compared to TKIs like sorafenib. Next slide, please. So this is one of our patient who had FDG with multiple well-defined arterial phase enhancing lesions in both lobes of liver in segment 8 and 6 and 5 of liver, showing portal and washout in a portal and delayed phases. The evidence of FDG with contiguous filling defects and tumor thrombosis seen in left portal vein and its branches, extending to main portal vein and RPV, just suggesting multicentric HCC. And there was a FDG with lytic lesion with soft tissue component involving multiple bones, suggestive of metastatic etiology. Next patient. So after immunotherapy, this patient had significant reduction in the number and size of enhancement and metabolic activity of most of the prior noted FDG with multiple defined APHE lesions in both the lobes of liver. There was complete metabolic resolution of prior noted tumor thrombus within the left portal vein and its branch, and there was near complete metabolic resolution with significant reduction in the size of soft tissue component, soft tissue metastasis, which was priorly noted FDG with multiple expansile lytic lesions involving the skeleton, and no interval new lesions or any other metabolic active lesions were noted. And next slide, please. Next slide, please. So it which indicates that even patients with higher tumor burden will do well with systemic therapy. Coming to the next myth, that is the best response to immunotherapy is in liver. However, the patients with lymph node, lung, liver, and other sites of metastasis also do well with immunotherapy. Next slide, please. So coming to organ-specific responses, liver response, the response rate is 27.8%, whereas lung response rate is 29% and lymph node is 42.2%. So the size reduction with respect to the target lesions in different specific responses indicates that it has a reasonable response in all the other sites apart from liver also. Next slide, please. Next myth is immunotherapy works only in the younger population. There are many studies which have done a subgroup analysis comparing the efficacy of immunotherapy in different age group of patients. Coming to one such study, that is Vithayatil et al., which was published in the year 2022 in Liver International, they showed that the response, the cumulative survival with respect to age, with respect to patients aged 60 plus and less than 65-year-old is comparable with immunotherapy, and even progression-free survival is comparable in both the both groups of patients. Next slide, please. And across all age groups, patients receiving atezo-bev combination had longer median OS in different groups. This is a subgroup analysis of IMbrave 150 study only. At three subgroup of patients, that is less than 65 years old, 65 to 75, and more than 75-year-old, they had comparable median OS and PFS, and compared to sorafenib arm, each age group of patients did better. The performance was much better with immunotherapy compared to sorafenib arm. That is, median OS and PFS in those receiving atezo-bev combination was much better compared to sorafenib arm. Next slide, please. The next myth is if we need to continue atezo-bev combination for lifelong. So as per trial, the drug is administered for almost 2 years or as long as the patient tolerate or do not progress on the medication. Nearly 80% of patients treated with atezo-bev combination achieve 30% of response, either complete or partial response within 4 doses, and others respond by other 20 respond by 6 doses. Next. No, next slide. Next slide. So myth is whether the risk of variceal bleeding is high with atezolizumab combination, and any clarity of management of these patients with high risk varices. So bevacizumab has been available since 2004, and the bleeding is unusual, but if it happens, it can be fatal. If a patient has been diagnosed with esophageal virus, screening is mandatory for all the patients prior to starting immunotherapy. Patients can be either chosen to treat either with beta blockers or EVL, depending upon the preference of the clinician. Usually, the bleeding risks are higher in patients with the main PVT. Coming to IMBRAVE 150 data, the variceal bleeding risks are almost comparable in both the groups, that is atezolizumab group and sorafenib group, and bleeding was similar in Child-Pugh A and B categories. And bleeding is similar irrespective of the type of prophylactic therapy chosen. However, the immune-related adverse effects are much more compared to in atezolizumab group compared to sorafenib group. However, they have different class-specific side effects like palmoplantar erythrodysplasia. Next slide, please. So coming to guideline statements by AASLD, patients considered for atezolizumab combination should undergo endoscopy to assess for high-risk stigmata of variceal bleed or other GI bleeding. And optimal treatment of large varices prior to atezolizumab combination initiation is still unknown. Although AASLD recommends at least one session of banding, carvedilol may be considered as an alternative for the management of varices prior to atezolizumab combination. Patients with recent bleeding within 6 months and those with high risk stigmata for bleeding on endoscopy should have varices adequately treated. That is, variceal eradication is recommended prior to atezolizumab combination initiation, and or these patients may be considered for durvalumab plus tremelimumab combination. So the main risk factor here is whether if they start bleeding, the bevacizumab may impair with the healing of this variceal bleeding, which can lead to catastrophic consequences. So these patients may be considered for durvalumab plus tremelimumab combination instead of atezolizumab combination. Next slide, please. So there have been different doses that have been tried to reduce the variceal bleeding. Bevacizumab at lower dose have been tried. However, it is safer to prescribe beta blocker and simvastatin if the mean arterial pressure allows. Avoid EVL in patients with main PVT. Next slide, please. So the myth is that you cannot perform liver transplant after immunotherapy. And next slide, please. There are multiple instances, multiple case reports across the world where patients after receiving immunotherapy have undergone liver transplant after a complete response, and the response post liver transplant has been good, and there have been patients who have been followed up for over 2 years without any recurrence also. Next slide, please. So coming to our AIG experience, 12 out of 115 patients have been downstaged. BCLC B and C categories included 5 and 7 patients respectively. 3 patients died on waitlist and 3 are awaiting LT. There are 4 LDLTs and 1 DDLT done. 1 resection following atezolizumab has been done. The time to transplant is 80 days. 4 patients had negative for microsatellite instability and low TMB, and 1 patient had high-risk mutations like TERT promoter or TP53 mutations. AFP, there were no patients who underwent transplant if initial AFP is more than 400. The median follow-up is 10 months, and wound complications are common among these patients. Next slide, please. So the myth is that if you can infuse immunotherapy at any time of the day, there are multiple studies done in different kind of malignancies like non-small cell lung cancer, RCC, melanoma, urothelial and esophageal cancers with in pooled analysis revealed that early time of the day group had longer overall survival and PFS compared to late time of the day groups. Next slide, please. The difference in this probably is the circadian rhythm is probably because of the release of glucocorticoids and potent immunosuppressors that peaks in the beginning of the day and reaches its lower levels during the first half of the night. Next slide, please. Next slide. To summarize, previous. The complete response is not uncommon. There's excellent overall survival and bridge to transplant is feasible. And the only problem is it's not economical and easily available and some unusual adverse effects. With this, I would like to conclude my talk and be open for any questions. Thank you.
Thank you, ma'am. If anyone has any question.
Dr. Soumya, in patients with active hepatitis B, hepatitis C, upfront diagnosis with HCC
Yes.
with active hepatitis. So what is your protocol? How do you manage? Do you give any window period or directly start away or everything?
Usually when it comes to other treatments like rituximab and all, we start 1 week prior and all that. But in these patients also, if they are newly diagnosed, I'm comfortable giving it after 2 weeks of therapy, 2 weeks of Hep C antivirals or 1 week of Hep B antivirals.
Okay, thank you.
Thank you, ma'am. Thank you, sir. We will move forward. For the next session, I would like to invite Dr. Srinivas Shetty. He is a consultant hepatology and liver transplant at Star Hospital, Hyderabad. He will give his talk on role of TKIs in metastatic HCC. It's over to you, sir.
So if you see, there is a hepatocellular carcinoma, there is one patient, but they have two diseases. One is underlying chronic liver disease associated with cirrhosis. So 80 to 90% of HCC patients have coexisting underlying liver cirrhosis and loss of normal oxygen and microcirculation and reduced hepatocyte mass and function and reduced regenerative availability. This is causing reduced liver functional reserve and reduced hypertrophic response and underlying portal hypertension, which related to increased risk of HCC. So if you see, once patient has developed cirrhosis, it will impact of liver decompensation on patient survival. In patients with compensated cirrhosis, the survival rate probably high when compared with the decompensated cirrhosis. So first thing is in hepatocellular carcinoma, there is a drug called doxorubicin, which was published in previously in almost 1998, which showed some anti-tumor therapy in patients with hepatocellular carcinoma and followed by sorafenib. And the timeline, how it was developed initially in 2007, the SHARP trial and Asian specific trial, the sorafenib was introduced, and slowly there is a lot of other drugs in the pipeline, and lenvatinib, which is a reflect trial, and adalimumab, bevacizumab, these are the immunotherapy drugs which are came in this way. And tyrosine kinase inhibitors like sorafenib, lenvatinib, and regorafenib and cabozantinib, all these things in the pipeline. But when compared to the previous speakers, the first line treatment is now is adalimumab, bevacizumab, followed by lenvatinib. So if you see the BCLC staging and treatment strategy for HCC, as we discussed previously also, when it comes to systemic therapy or tyrosine inhibitors, only mainly if you see in B or C stage, advanced stage with portal invasion and extrahepatic spread, or intermediate states, multinodular with preserved liver functions, or some patients post TACE or post TAE, we need to keep on tyrosine kinase inhibitors. So the optimal transition from loco-regional therapy to systemic therapy is evolving. If we see here, mostly usually up to early BCLC and extensive BCLC-B, we can give loco-regional therapy, and followed at the same time, we can start with systemic therapy. And if you come down to BCLC-C, and if more of systemic therapy is important than loco-regional therapy. So the treatment options for first-line advanced HCC, as we discussed previously also, atezolizumab plus bevacizumab, followed by durvalumab plus tremelimumab, according to the Himalayas trial, and then lenvatinib and sorafenib. The second-line treatment in advanced HCC is cabozantinib and regorafenib and ramucirumab. So as we, for a tyrosine kinase inhibitor, these are the two studies, majorly SHARP trial and ASIN-specific trial, where showed the sorafenib consistently increased overall survival in different patient population across the geographic regions. If you see that median overall survival rate also 10.7 versus 7.9% in patients. In the ASIN-specific trial also, the median survival is showed 6.5 versus placebo is 4.2. So this is a reflect trial where the lenvatinib versus sorafenib trial, which is a randomized open label trial, but it is a non-inferior trial, but which was showed both are same lenvatinib and sorafenib, and it is not inferior, and it is more or less non-inferior trial, which was showed good response. If you see here, lenvatinib 13.6 overall median overall survival rate when compared to sorafenib is 12.3% with the hazard ratio 0.9 only, and median overall survival probability of progressive free survival is lenvatinib is 7.4 months versus sorafenib is 3.7%. So summary of first-line treatment efficacy versus sorafenib, as we discussed here, Umbrella 150 Himalaya trial showed that sorafenib is inferior to the immunotherapy with median overall survival rate. So as these, when we compare to the reflect trial, sorafenib and lenvatinib is non-inferior trial. So remember, sorafenib is the first line drug when it is come when its trials has came up. Now atezolizumab plus bevacizumab is first line treatment. Then sorafenib. So does immunotherapy has limited benefits in NASH-related HCC? This is the meta-analysis of 3 large phase 3 clinical trials showed that immunotherapy improved overall survival in overall population and in viral HCC, but not necessarily in non-viral HCC when compared with immunotherapy. So when compared to the real world data, if you see, and lenvatinib reduces the risk of death by 54% and risk of regression by 48% versus atezolizumab plus bevacizumab. So this is a retrospective data of prospectively collected BCLC B study, where showed that lenvatinib showed median overall survival is little 21.21 versus atezolizumab plus bevacizumab. So what is the optimal sequencing in second line? So these are some of the studies, resource trial and celestial trial and reach2 trial showed that when compared to the regorafenib versus placebo, cabozantinib versus placebo, and ramucirumab versus placebo, the median overall survivability is better when compared to placebo 10.6 months, but when compared to sorafenib it is 13.6 months, and celestial trial the median survival is 10.2, and reach2 trial median survival rate is 8.5%, 5 months. So choosing the second line after atezolizumab plus bevacizumab, then followed by sorafenib, lenvatinib in the pipeline, followed by regorafenib, then cabozantinib, then ramucirumab. The hazard ratio is 0.63 for regorafenib, and cabozantinib is 0.76, and ramucirumab is 0.71. So this is some of the studies, space trial of sorafenib or placebo plus deptase. So randomized, this is the phase 2 trial in patients with BCLC B stage who received deptase plus sorafenib versus placebo. When compared to here, not median overall survival is more or less same when comparable. So this is the launch trial lenvatinib plus TACE versus lenvatinib as a frontline treatment for advanced HCC, which was showed lenvatinib plus TACE showed overall survival of 78 months when compared to the 11 months with lenvatinib alone. So these are some of the ongoing phase 3 HCC clinical trials. It's TACE combinations with immunotherapy plus lenvatinib plus immunotherapy plus TACE versus placebo. Still, recruitment is ongoing on. So even there is some of this trial, strong trial, there is a new adjuvant therapy in early stage HCC where there was showed there is some recurrent free survival is there, but not that much comparable. So what about treatment of advanced HCC in India? So there are the challenges are there in India. There are so many people, the percent of the people in each state is where are the poor, they may not tolerate this immunotherapy when there is an advanced HCC with extrahepatic metastasis. So what are the next options? What is the solution? What is our problem? So there are some of the studies which was showed that we can with the poo in some centers we can treat with TACE plus sorafenib, where shows there are some good survival when compared to TACE alone. So these are the some because et al. Which was showed some of the study where these patients were advanced HCC patients were included. The median, the 39 patients were started with 800 milligrams of sorafenib was for 6 months. They have tolerated very well, and advanced median overall survival rate is also good. Almost is going up to 13.8 months when compared to placebo. So these are the phase 1 study evaluating those of de-escalation of sorafenib with metformin with atorvastatin also in patients with hepatocellular carcinoma. The combination is superior when along with the alone sorafenib, but still studies are going on. So when this comes to HCC, the essential treatment is multidisciplinary approach when oncology, hepatobiliary surgery, radiology, pathophysiology, and hepatology and liver transplant program. Every should be involved. When to go for transplant, when to go for resection, and when to start immunotherapy. When if the patient is not feasible for immunotherapy, when to start TK is also very important. So TK would continue remain mainstay of advanced HCC. The survival with sorafenib has increased over a period of time. Now the dose, the lenvatinib also remain the rows of option in first line after sorafenib. The next is third line is cabozantinib and regorafenib remain option for second and subsequent lines. So thank you so much for your kind of attention. But still, some of the patients with NASH related CLD, we should strive with immunotherapy. If not work, better to start with TKs, which was showed, the data showed that TK has some promising overall survival rate when compared to immunotherapy. Thank you so much. Hello. Thank you, sir.
Thank you, sir, for your talk. For the next session, I would like to invite Dr. Arif Khan.
Can I get my slides? Good evening, Vishal.
Sir, I am sharing the slide.
Okay.
Slide is visible.
Yeah, slides are visible. You will be moving the slides now.
Yes, sir.
Okay. So good evening, everyone. I welcome you all for today's session. I am Dr. Arif, consultant medical oncologist at AG Hospital. At the outset, I would like to thank Dr. Anand and the Roche team for giving me this opportunity. Basically, I will be talking about the selection of patients for immunotherapy. It's more or less revisiting the same thing which have been discussed by the previous speakers. They have elaborately discussed about what are the indications for immunotherapy in HCC and where we consider it. And basically, I will be revising all those indications. And it will be looking like somewhat repetition, but this is how it is that the SCC, we have got multiple options. Immunotherapy is one of the option. Then TKS are the option. Majority of the patients still in our country opt for TKI. Immunotherapy is considered in only minority subset of patients at presentation because of the cost related factors. And immunotherapy had made a huge difference in the survival of HCC. It has improved the survival 2 years, and the HCC, we did not expect a survival beyond 1 year before the discovery of this immunotherapy. Among the immunotherapy, we have got choices now. We have got Himalaya. We have got Atezobev. Atezobev was first one to come. We have a lot of experience with this immunotherapy. We know that it works very well in those advanced SCC patients. So epidemiology, it's already been discussed, but to rebrush it, primary liver cancer, we know that it is the sixth most common cancer worldwide, and it is third leading cause of cancer-related deaths. HCC, among the primary liver cancer, HCC is most common. The cholangios and other histologies are not so common. HCC accounts for around 75 to 85% of primary liver cancer cases. Usually, males are affected majorly. It's more common in men than women, and the incidence and mortality is slowly and steadily it has increased till 2010, and after that it has started to decrease. Now the incidence is decreasing. Maybe we are addressing the viral hepatitis, even the metabolic factors like NASH related HCC. The people are becoming more aware, and the lifestyle related factors are decreasing now. So that may be the cause that the incidence of HCC is somewhat decreasing now, and the mortality is also plateaued since 2013. So next slide. So coming to incidence geographically, we can see here that those in the dark color, the dark blue, these are the highest incidence countries. So North America, and we can see the East Asia is has the highest incidence of HCC. The India comes in between. It has around second most common site, but the etiology we can see here in the North America, it's usually HCV related HCC is very common there. The alcohol and HBV is not so common, but majorly HCV accounts for most of the cases of HCC in North America. And in East Asia, we can see that hepatitis B is most commonly associated with the HCC. The risk factors vary according to the geographic region. So the North America, it's hepatitis C, and in the East Asia, it is majorly hepatitis B. So India, we have got in our setup, we see even viral related hepatitis causing the HCC and also NASH related, though we are seeing increasing number of non-viral HCCs nowadays. The hepat department, they see almost all cases viral hepatitis related HCC and NASH related. That's what they tell us, that NASH related HCC is becoming more common nowadays. So next slide. There are some prevention strategies for HCC: primary prevention, secondary prevention, and tertiary prevention. How we can primary prevent is by vaccinating all the individuals by HBV vaccines and other treatment. And we can use some lifestyle modifying factors, like coffee is somewhat protects against the liver disease. We have aspirin, statins, and metformin. All they have some evidence that these prevent the occurrence of CLD. But majorly, the vaccines are more important in preventing the occurrence of CLD and HCC. Secondary prevention is when we diagnose this disease early and we treat them very early. So that is secondary prevention by doing screening methods like ultrasound and AFP and detecting the disease at the early stage. Then comes the tertiary prevention. Tertiary prevention is once the disease has already occurred, that there's already HCC has developed, and we treat those cancer. And after treating, there are some uh, strategies available to prevent the recurrence. So adjuvant immunotherapy, as discussed by previous speakers, that though it showed initial improvement in the DFS, at prolonged follow-up, what we have seen is that it's not effective in the adjuvant setting. So atezobev immunotherapy is not effective in the adjuvant setting. It's still to be considered in the advanced HCC. So moving to the next slide. So we are all aware of this BCLC staging. We have extensively discussed about this. What are the stages and how to treat them? What are the treatment options? So basically, the disease is confined to the liver. Then we consider local regional therapies. Once we exhaust the local regional therapies, we move on to systemic therapy, and the stage moves further. So advanced stages, metastatic. If there's extrahepatic disease, and then we consider systemic therapy as the treatment. Next slide. So systemic therapy we consider in unresectable HCC, those patients not suitable for local regional therapies like BCLC-C, and in some patients with intermediate stage HCC, BCLC-B, where we exhausted all the local regional therapies and the patient is not fit for the local regional therapies. There's beyond 7 criteria and all those criteria which we know that the local therapy doesn't benefit the patients, and we move on to systemic therapies in intermediate state HCC. And all these are the options we have in the systemic therapies. As immune checkpoint inhibitors, Santosh has already discussed PD-1, PD-L1. So PD-1, we know that Pembro and Nivo in the second line, PD-L1 Atezo and Durva in the first line, CTLA-4 again, Tremi and EP in the second line, and Tremi in the first line. And these are all the options we have got now. We have got the robust evidence to back up this treatment. And also we have TKIs. TKIs are form the major form of treatment for advanced SCC in our country. Lenvatinib, sorafenib is a age-old drug. No, most of the treatment is it's not based on sorafenib nowadays. So it is moving out of the treatment options now. Lenvatinib is considered, cabozantinib, regorafenib, all those TKS in the second line. These are some of the approvals, and bevacizumab and ramucirumab again in the second line, bevacizumab in the first line. So next slide. So coming to the algorithm of this treatment of advanced stage SCC and the intermediate stage SCC, we will look for the liver function, assess the liver function, Child-Pugh score. If the patient is fit for the treatment, look if he's eligible for immunotherapy, then we look for the contraindications. So autoimmune disorders need to be ruled out, and also the liver transplantation status. So immunotherapy can be considered before the liver transplantation, but we don't have any much data after the liver transplantation. After liver transplantation, if the patient develops HCC, whether recurrence, then we can use immunotherapy or not. That is a questionable. Then we can answer this, take up these questions in the question and answer session. And liver transplantation, we need some form of immunosuppression for a long time, and basically immunotherapy will not work, and there is again a chance of flare up of immune related hepatitis in the transplanted liver. That is also one point we need to be worried about. And also when the patient is doesn't have contraindications to immunotherapy, we look at the bleeding risk. So in CLD with portal hypertension, we need to rule out the varices. So varices, according to grading, we treat the varices, so band ligation or just conservative management. And if there are no varices, then atezo-bev can be considered as the first line immunotherapy of choice. If there are varices, then durva and tremi seem to be the reasonable option. But if the varices are already treated, even atezo-bev can be considered. I'm going to discuss about that in the subsequent slides. And sorafenib, lenvatinib are not so popular options, but if the patient is not eligible for immunotherapy, cost-related factors, lenvatinib or sorafenib can be considered. And once the disease progresses on the first line, we have got regorafenib, cabozantinib, ramucirumab, and also the patient is not exposed to immunotherapy in the first line, we consider nivo, ipi, or pembro in the second line. Next slide. So IM Brave, we talk about IM Brave 150. This was the landmark trial which led to the approval of atezo-bev, showing robust activity in the advanced HCC. But this is the only trial which included the high-risk features patients. So high risk like portal vein invasion was included in IM Brave. Tumor volume. So the higher tumor burden patients were also included in this study, which were not included in other studies like Himalaya or other, the Reflect trial and all those trials. These patients were excluded in those trials. So hepatic vein thrombus and inferior vena cava thrombus, all those high-risk patients, these portend a very poor prognosis. So even in this presence of high-risk features, we have seen the benefit of this atezo-bev. So what this, according to the subgroup analysis they have done, they have seen that the hazard ratios in the high risk and non-high risk patients were almost similar, though there was numerically better survival in the low risk patients, but the high risk patients also had a meaningful improvement in the survival, and the hazard ratio were almost similar. So numerically, we can't take the survival as the survival can be taken only based on the numerical values. We have to look at the hazard ratios to get the interpretation that even in the high risk patients, this atezo-bev combination works very well. Next slide. This is another one controversial area, whether the etiology affects the response to immunotherapy or not. Again, it was again by the exploratory subgroup analysis. This was answered in this trial that atezo-bev shows a meaningful efficacy and tolerable safety profile in both viral and non-viral population. This is based on both the trial IM Brave 150 and also the real-world evidence studies. Though in the non-viral etiology subgroup, the median OS was 17 months. Now, in intent to treat was around 19.2 months. So it works very well even in the non-viral population. And as compared to the durva-tremi, the survival is almost better by 1 month. So though we can't do a cross-trial comparison, but for some indication of the efficacy, we know that even in the non-viral subgroup, atezo-bev works very well. Based on the real-world evidence studies like ABREAL study, whether it is in the viral ASH, the alcoholic related CLD or NASH related CLD, the etiology doesn't affect the OS outcomes when treated with atezolizumab. Next slide. Liver function status. This is one area we need to look on that, because if the liver function is poor, then the patients do not tolerate immunotherapy very well. This is again seen in all the real world evidence studies, one by Dr. Anand. That beautifully substantiated that if we use the immunotherapy in poor liver function status patients, this doesn't work. So we are dealing with two diseases, as previous speakers told, that CLD and the tumor. If we give this immunotherapy in very poor liver function patients, the liver decompensates. So this liver decompensation has very adverse effect on the survival. Most of the patients do not recover from this once the liver function gets deteriorated. So chemoimmunotherapy, we have seen that in the real world studies, even the atezolizumab, it is used till B7. So B7 is the cutoff where we should consider some form of immunotherapy to be given. If the liver function status crosses B7, then we should not be using any immunotherapy. So that's what it is substantiated with many of the real world studies and also the clinical trial, the IMBRAVE 150. So moving on to next slide. Next slide. So again, this slide by Dr. Anand, this is a real world evidence study, 67 patients of unresectable HCC treated with atezolizumab, OSPFS as the primary outcomes. As we can see that the poorer the liver function, the worse the survival. So child PUA has a better survival as compared to child PUB, and child PUB better survival than the child PUC. So liver function, we should be considering very strongly to consider whether immunotherapy will be effective in this patient or not. Liver function should be ideally considered in every patient, and more than B7, immunotherapy should not be considered. Next slide. The other important factor which we need to consider is esophageal varices. So most of the patients have CLD, portal hypertension. Varices are very common. Does presence of varices affect the response to immunotherapy or not? That it leads to increased complications. That's what it has been seen in many of the studies here. One study showed that presence of varices indicates a very poor prognosis. It is linked to the tumor burden, and it shows a 5-year worse survival. So 24% with the presence of varices, as opposed to 46% 5-year overall survival in the absence of varices. So we can consider band ligation or treating these varices before starting. So grade 1 and 2 beta blockers are considered. Grade 3 and 4 requires banding, even in those patients presented who have varices, and these have been included in the atezolizumab study, IMBRAVE 150. They have included all those patients who had varices, and those having high grade varices were treated before the inclusion in this study. And it showed that atezolizumab is highly efficient in and the safety profile was also maintained in the presence of varices. Subgroup analysis, they showed that the patients having varices, those who were treated before inclusion, had an improvement in the survival, 17.7 months. The subgroup with varices also had shown a improvement in the survival as opposed to sorafenib. When should we consider that is after treating the varices? The ideal time from all the real world studies and also the IMBRAVE 150 is around 2 weeks after treating the varices. We have to wait for 2 weeks, and then we can start with immunotherapy. Next slide, Vishal. So BCLP was one. So these are the tumors which are confined to the liver, and whether this immunotherapy works in this BCLCB or not. So it's highly efficient here also in this scenario where we have exhausted the local regional therapies, and the tumor has become refractory to local regional therapy, or if it is unsuitable for local regional, like it has bilobar disease, it's above beyond the 7 criteria where TACE or TARE could not be considered. If it has portal vein thrombosis, then in this subset of patients, this immunotherapy is one of the options. In IMBRAVE 150, they included around 74 patients with BCLC-B, accounting for 15% of trial patients, and randomized to be 49 were randomized to atezobev, 24 to sorafenib, and of these patients, 21 patients had received prior TACE. The secondary analysis, they showed that median OS was significantly improved in BCLC-B, 25 versus 21, and PFS also 12 versus 8. Hazard ratio again significant 0.6. And overall response rates were also better in BCLC-B, 43 versus 26. Also according to the modified RECIST, 50 versus 30. So the atezobev is also very effective in BCLC-B patients who have become refractory to local regional therapies or unsuitable for local regional therapies. This I'd like to conclude that selection of appropriate patient profiles for best treatment outcomes with immunotherapy in HCC is very important. Majority of clinical trials have shown best possible outcomes in patients with good liver function and those without risk of varices or major vessel involvement. But real-world evidences may help us with the guidance on management of HCC with advanced stages and compromised liver functions and other complications such as varices or portal vein involvement. So with this, I would like to conclude my talk. I thank you all for your patient hearing, and I think questions can be taken in the question and answer session. I hand over to Vishal for his further.
Thank you, Arif sir. For the next talk, I would like to invite Dr. Anand Kulkarni sir. He will give his talk on immunotherapy in grade 3 partial blooding. It's over to you, sir.
Thank you, Nishant and his team for organizing this. It's been exciting to hear all these advancements in HCC, the epidemiology, treatment aspects, the myths and facts, and Dr. Arif's exciting talk on immunotherapy and choosing the appropriate drug. As a hepatologist, I'll be touching upon portal hypertension aspect of cirrhosis and HCC and the role of immunotherapy in these patients with variceal bleeding. And we know that variceal bleeding is a threatening complication of portal hypertension. If a patient of HCC whose child has cirrhosis but doesn't have clinically significant portal hypertension, that is CSPH, that is HUPG more than 10, his survival is 70% at 5 years. If this patient has clinically significant portal hypertension, that is HUPG more than 10, or varices as said by Dr. Arif, any kind of portal hypertension evidence, the survival reduces to 25 to 50% at 5 years. So it's almost 1/4 in patients who have portal hypertension, even despite having a child per age status. So portal hypertension plays a significant role for these patients with HCC and cirrhosis. This is a recently published article in Hepatology. So what are the common pathways? Why you are worried about this? In patient with cirrhosis, we know that these patients have a increased risk of developing the prevalence of variceal. Apologies for the delay. These patients, the prevalence of HCC, variceal bleeding in patients with HCC is 2 to 15%. And this is a marker of poor survival and is also a marker of advanced disease. The previous studies published in American Journal of Gastro in 2004, they said that at that time there was no systemic therapy, there was no advanced therapies for HCC. And they noted that these patients have a survival of 3.5 months who are present with variceal bleeding compared to 7.5 months who have variceal bleeding. The survival of these patients drastically reduces if they have portal hypertension or any evidence of variceal bleeding. A recent publication from Asia in Thailand, it was basically a retrospective study, not a great study, although it has several important messages. There are 333 patients who were included. 27 patients, 8% had documented variceal bleeding at presentation. And these patients who had variceal bleeding had poorer survival. If you see this patient at the end, in HCC patient with variceal bleeding, the 1 and 2.5 year survival rate is 50% and 28%, pretty low. On multivariate analysis, presence of ascites, Child-Pugh score more than 6, presence of varices, or having were risk factors for variceal bleeding in HCC. The odds ratio increased significantly to 7.59. So we know that now portal hypertension has common pathophysiology along with HCC. It has similar mechanisms. The risk of bleeding is around 2 to 15%. They have high mortality. Why are we concerned in respect to systemic therapy? The reason being, the landmark publication in NEGM said that there is risk of variceal bleeding in patients who receive bevacizumab. And most of our colleagues, our gastro colleagues and onco colleagues fear about the risk of variceal bleeding. And how does bevacizumab cause variceal bleeding? Does it lead to increased rupture? There is some studies to suggest that this because of inhibition of VEGF, there is impaired vascular repair, there is endothelial dysfunction, which can lead to more ulcer-related bleeding, especially in those who have undergone variceal ligation. There is increased vessel fragility because of this VEGF inhibition. Since it inhibits VEGF also, there is collaterals which actually required to decompress the portal hypertension. So VEGF inhibition may prevent the formation of collaterals and lead to worsening of portal hypertension. Also, this is actually conflicting. There are some studies to say that these immunotherapy agents can directly increase the portal pressure as well, which I will be showing in the next slides. Second, reduction of VEGF may increase the portal hypertension by impairing the hepatocyte's ability to receive the oxygen nutrients. So you inhibit VEGF, the cell doesn't get its oxygen or nutrients. It leads to increase in inflammatory cell infiltrates. And when we are giving atezolizumab, it may stimulate the innate immune cells and increase the production of pro-inflammatory cytokines, leading to formation of fibrosis. So there is no counteraction for reduction of portal hypertension. The collaterals are unable to form. There is increased fibrosis. The portal hypertension increases. This can be true for any of the immunotherapies. It's not specific for this drug, but the studies have been suggested for this drug specifically. But when this happens, the patients then to develop variceal bleeding. This has been also been showed for patients with lenvatinib. When they give lenvatinib and after 14 days, when they evaluate it, the oxygen supply to the cells of a liver, there is reduction in the oxygen supply, which led to increased fibrosis. These are all basically theoretical aspects, but yes, there is some evidence any of this systemic therapy can lead to worsening of portal hypertension in one way or the other. So this case report of two patients, here what they reported is when you give abetizumab, few weeks later, the patients had increased clinic volume. This clinic volume increased from 207 to 255 ml. The total diameter of collaterals, which also increased from 14.8 to 8.1. This is contradictory to what I said before. So, but some evidence to support that there is a rise in portal hypertension. What happens in real world? The NEGM, I believe everybody has talked about the study. Let us discuss about the current, our original study, which has been published in JCEH. We had few patients, 67 patients who were treated with atezolizumab, which is a first-line recommended drug. Our aim was to assess the progression-free survival and overall survival. But if you see the adverse events here, two patients had variceal bleeding. One who had a prior history of variceal bleed also had presented with variceal bleeding. Second, who had portal vein thrombosis, bled after 4 cycles. The first patient died within at the initial presentation itself. That is, variceal bleed-related mortality was almost 50% if we compare these two. Second patient was alive, was taking atezolizumab alone, but no much disease improvement, so changed to lenvatinib. Similarly, the common side effects, what we note is not variceal bleeding. This is something like fatigue, rise in bilirubin might be seen, hypertension, fever, proteinuria is very common, epistaxis. Hoarseness of voice is also common. If you ask this patient, they will always complain of change in voice. Ascites in some patients, again, probably due to rise in portal hypertension. Oral ulcer, skin rash, not variceal bleeding as such. This was the initial study published in Clinical Gastroenterology and Hepatology. 194 patients who had undergone, 102 had undergone endoscopy, and 17 had high-risk varices. The time to bleed was approximately 1.8 months. That is, after around 2 doses, they usually bleed. 8 patients had developed variceal bleeding. If you see here, what are the predictors of variceal bleeding? The only important predictor here was presence of portal vein thrombosis. Despite receiving prophylactic EVL, there is no decrease in the incidence of variceal bleeding. So, PVT is a major risk factor for development of variceal bleeding post-immunotherapy, post-atezolizumab. When we did a large meta-analysis published in one of the Lancet journals, the cumulative prevalence incidence was 4.7%, and it was similar between child A and child B. It was higher in patients who had portal vein thrombosis, again upholding what was published in CGH. Bleeding was similar, irrespective of the prophylactic therapy, ligation or beta blockers, there is no much role. And there are some immune-related adverse events noted around 10%. So, bevacizumab, which has been available for more than 2 decades, bleeding is actually unusual, but definitely fatal. There is no doubt about it. We have to treat portal hypertension in these patients with HCC and cirrhosis. So again, a similar study suggesting that portal vein invasion is an important marker of variceal bleeding in these patients with HCC. What does ASLD say about this? How do we assess this portal hypertension? Patients considered for atezolizumab should undergo an EGD to assess high-risk varices. I am in favor of doing endoscopy for all patients with HCC to evaluate for portal hypertension. I will give my strong recommendations because there is a recent publication as well, which we have been following clinically, has been published in hepatology, saying that every patient should undergo esophageal variceal screening urine using endoscopy to evaluate for portal hypertension. Unless you are very sure that the tumors are pretty small and fibroscan is absolutely normal, or less than 13 is the indication. KPA 13 is considered as non-cirrhotic in patient with HCC. The optimal treatment of large varices prior to this combination is actually unknown. Although ASLD recommends that at least one session of EVL has to be done, and carvedilol may be considered as an alternative management of varices prior to atezolizumab. There have been few studies evaluating the role of simvastatin. We have our own publication which is in review. This use of simvastatin is common in patients with HCC and large varices. It reduces the risk of bleeding only in large varices, but may not be beneficial in earlier grade 1 varices. Patients who had recent GI bleeding within 6 months and those with high risk stigmata for bleeding on EGD should have varices adequately treated prior to atezolizumab initiation, or these patients may be considered for other therapies. This I'm not pretty sure. I have not been very comfortable using the other recommended drugs as of now. But yes, if the patient has controlled well bleeding and the patient has eradicated varices, as Dr. Arif also mentioned, that it may be okay to start them on atezolizumab rather than giving them other therapies which are suboptimal in efficacy. So how do we prevent acute variceal bleeding in patients who are treated with this? The recommended dose of bevacizumab, which was based on the initial study published in Lancet Oncology, was 15 mg per kg body weight. But recent studies have suggested that a low dose may be efficacious for these patients who have HCC and may benefit from using low dose of bevacizumab for these patients. One of the studies has also used 500 mg of bevacizumab fixed dose. Some centers are using only 400 mg. I have been used to using only 10 mg per kg body weight. So its preference, it is efficacious at 10 mg per kg body weight. We have used for 400 mg for a few of the patients, but didn't find it to be quite effective. So we have increased the dose to 10 mg per kg body weight. And definitely all these patients have to be screened, added them on beta blocker and simvastatin if possible. Management revolves on screening and risk assessment, mandatory endoscopic evaluation for patients planned for any sort of systemic therapy for HCC or any sort of treatment for HCC. It is imperative to evaluate for portal hypertension. Even if the patient is undergoing a small tumor resection, it is suggested to evaluate for portal hypertension because presence of portal hypertension may increase the risk of post-surgical decompensation. So that is the reason we have to evaluate for portal hypertension. Whatever way you want, endoscopy is must for patients who undergo systemic therapy. Prophylactic therapies optimize non-selective beta blockers. Carvedilol is preferred because the alpha action of carvedilol rather than propranolol although there is some role of propranolol in patients who are decompensated cirrhosis, but in patients with HCC, carvedilol is a suggested drug. You may consider adding simvastatin, which has pleiotropic effect, which can reduce the portal hypertension in these patients. Can also do endoscopic variceal ligation. It is suggested to do at least one ligation prior to initiation of this drug. It is recommended that the patients have eradicated varices. During that period, we tend to give some form of immunosystemic therapy like lenvatinib or any other therapies. Or if the patient is suitable for any locoregional therapy, he can also undergo locoregional therapy. Obviously, every patient is and should be receiving personalized treatment. Tailored approaches based on variceal grade and comorbidities is must. One of the studies which used reduction in reduced dose or discontinuation of bevacizumab, what they noted was one of the patients. It was a small case report. A few patients who had reduction in dose had reduction in the incidence of variceal bleeding, despite having a history of variceal bleeding. But few patients did not. So success rate is contradictory. You may or may not continue. We usually prefer to discontinue the drug once the patient develops variceal bleed. Do patients receiving other form of systemic therapy, which is lenvatinib, do they bleed? Yes, definitely. This is a publication from a European multicenter study where 553 patients were included. The median age was 72 years. 89% were in child pug A. 16% had neoplastic portal vein thrombosis. Most of them were in BCLC-C. What they noted was during lenvatinib treatment, 17 patients had bled from esophageal gastric varices, 3 grade 5, that is death because of variceal bleed. The 12-month cumulative incidence being 3%, which is similar to what we actually have been selling for atezolizumab. The only independent predictor of gastric variceal bleeding, esophageal gastric variceal bleeding, was the presence of high-risk varices. So any patient who has high-risk varices has to undergo screening, has to receive EVL, has to receive beta blockers, and if possible, simvastatin to reduce the risk of bleeding, even irrespective of the type of therapy you are planning for. It is not that you are just giving atezolizumab and you are giving them prophylactic therapy. Even if you are giving them lenvatinib, please ensure that these patients receive appropriate prophylaxis to reduce the risk of bleeding. In these patients, the 12-month risk was 17%. High-risk varices was independently associated with child pug B score, neoplastic portal vein thrombosis, and platelets less than 150, which is a marker of portal hypertension. So in patients who are treated with lenvatinib, the risk of variceal bleeding is low, probably, yes, but significantly only in those with high-risk varices. And it is must to treat these patients. There are certain differences between IOs and TKIs. TKIs are quite economical, easily available. They provide decent overall survival. There are no unusual adverse events which is not known to anybody. But the disadvantages are there are certain adverse events which are quite common. Patients don't tolerate. All of our patients don't tolerate 4 to 8 mg of lenvatinib, not more than that. Complete response is rare. As a bridge to transplant, again rare. It can be used in post-transplant settings, but not as a bridge to transplant. Well, IOs, their complete response is not uncommon. It is seen in at least 10 to 12%. It acts as excellent overall survival as a bridge. The problem with them is it is not easily available, not economical. There are unusual adverse events which you have to be aware of, but once you know that it's quite easy to manage these patients. Post-LT use is not recommended as of now, although there are few studies which are undergoing on this aspect in other countries. Adverse events like hepatitis, bleed, proteinuria, and hypertension are common. This is we have seen for patients with ASLD guidelines. What they have noted here is patients who are advanced in HCC, if they have contraindications for immunotherapy like autoimmune disorder or transplantation.
Can I go down for that?
Autoimmune disorder or a patient has any other high risk of gastrointestinal esophageal variceal bleeding, the patients need to undergo either receive either sorafenib or lenvatinib. Or if the patient has high risk of gastrointestinal esophageal variceal bleeding, they may also receive the combination of tremelimumab and durvalumab. The first line recommended drug is atezolizumab if the patient do not have high risk history of gastrointestinal variceal bleeding. If these patients progress, then you may take up our second line therapies, which has been suggested. This I am not quite comfortable using these drugs, other drugs, because we have already seen that patients with lenvatinib also may have risk of variceal bleeding if they have a high risk of prior history of GI and esophageal variceal bleeding. There are two patients who had history of variceal bleeding. We started on lenvatinib, then developed variceal bleeding post lenvatinib as well. And our experience with the combination, which has been recommended for these patients, the recent patient, 60-year-old patient with NASH, who had history of prior variceal bleeding, has large varices and gastric varices, underwent EVL and glue. Then he later presented with pain abdomen. Was found to have a HCC with portal vein thrombosis. We followed what is recommended actually for these patients. We did SPRT for the portal vein thrombosis. We did a screening endoscopy which showed small varices with gastric varices. We initiated him on beta blockers. He did not tolerate for a few days, then changed again to simvastatin, again added on carvedilol. We proceeded with the recommended therapy as per the ASLD, but the patient then developed bleed and liver failure within 2 weeks of initiation of this therapy. And we lost the patient because of the variceal bleed, persistent variceal bleed. We did all sorts of therapy. US glue coil was done initial stage, then the EVL was done for this patient. He got again admitted for again variceal bleeding. Patient received Danicella's stenting as well. The initial after two variceal ligation as well, there was no control. We did put a stenting, but we could not make the patient survive. So I won't be comfortable following this regimen as such. This is all patients prefer, and if you are comfortable using, if the patient has eradicated varices, all of them are equal risk of variceal bleeding. This is a recent recommendation. If a patient has LSM less than 25 kilopascals, it is suggested to do a screening endoscopy. Irrespective of that, do a screening endoscopy for all. If the patient doesn't have esophageal varices, you tend to do a regular endoscopy annually. There is no need of any prophylaxis. If the patient of esophageal varices or gastric varices, any size, regardless of the size, start them on non-selective beta blockers. If there are any contraindications or if the patient doesn't tolerate, you can change to endoscopic band ligation or cyanoacrylate injection. If the patient has LSM more than 25, this is a proposal by Dominic Thabut published in Hepatology. I am very much favor of this, that if a patient has LSM more than 25, irrespective of the etiology, you may start them on beta blockers even if you don't have access to endoscopy. But I would prefer to do endoscopy prior to initiation for documentation at least. If a patient has indication of systemic treatment, no esophageal varices, no endoprophylaxis. If the patient has any kind of varices, start them on beta blockers. In case of history of variceal bleeding, we treat the patient with band ligation and non-selective beta blocker, which is the recommended treatment as per the Boveno. Thank you. I'd be happy to take any questions if there are.
Thank you, Dr. Anand sir. If there is no question, we will move forward. For the next talk, I would like to invite Dr. Veni Shetty Sanathan. He is a pathologist at Hyderabad. He will present a case on HCC. It's over to you, sir.
Yeah, thank you for the introduction and good evening, everyone. So I'll like share my slides. Yeah, are my slides visible?
No, sir, no visible.
Just a minute. Yeah, are they visible now?
Yes, sir, visible.
Yeah. So I'd like to take you through a case. Then accordingly, we can discuss about this. So it's a case of Mr. G, a 55-year-old male weighing around 58 kgs with no family history of liver disease, no family history of cancer, known type 2 diabetes since the past 10 years with HbA1c currently of 7.6, hypertension since past 20 years and current BMI coming up to 19.6. So the presenting complaint was right hypochondriac pain and discomforts in the past 1 month. The right hypochondriac pain was non-radiating. There were no aggravating or relieving factors. It was dragging type of pain and continuous and temporarily relieved with paracetamol. There was also a weight loss around 3 kgs over 3 months, which is unintentional. Outside ultrasound abdomen was 7.5 into 8.7 centimeter large SOL in the left lobe. So in examination, there was no pallor, no icterus, and there is no palpable lymphadenopathy. It was pulse rate, blood pressure on the limits, and respiratory system was normal. But abdomen showed a left lobe which is palpable 2 centimeter firm and non-tender with a spleen of 2 centimeter left coastal margin. As you can see with the labs, yeah, as you can see now the labs, patient was mild anemic with 11.2 of hemoglobin. Otherwise, the synthetic function and along the other liver functions were within normal limits. Albumin was fairly good, 3.7, but AFP was 5.8 with CA19 was 28, and there's significant elevation of PIVCA, which is 2,225. So post this, we have done a triphasic PET-CT, which was done because of triphasic PET-CT because of higher elevated PIVCA and along with low AFP. It was a triphasic PET on 4/5, which is 4th of May 2024. There was arterialization of the portal vein thrombus, which was there, along with basically there's an infiltrated type of lesion. There's non-homogeneous type of lesion which is there. The enhancement pattern was not so typical of HCC, but it was diffuse over the whole complete left lobe. And you can see even in the arterial phase, along the portal vein radicals, there was increased enhancement. The enhancement pattern of the portal vein thrombus was suggestive of HCC, but the enhancement pattern of the tumor itself was not so classical of HCC. There was varied components of solid along with some amount of hypodense component, which is seen in the segment 4. So the reported was around, there was multiple FDG, mild FDG avid. As you can know that HCC is not completely avid in well-differentiated type of HCC. Also, there is contiguous FDG avid thrombus in RPPV, LPPV, and RAPV, which is occupying the whole of the left lobe. And also there are FDG avid multiple enhancing lymph nodes which are there, the maximum of 1.7 into 1 centimeter. The endoscopy was showing grade 2 with RCS. So the diagnosis was made of cirrhosis of liver with likely MASL-related portal hypertension, non-bleeder, grade 2 varices with RCS, and type 2 diabetes with hypertension. There's an SOL liver with VP4 tumor thrombosis with extrahepatic spread such as lymph nodes. The performance status was 0, AF5 and MELD of 8. AFP was 5.8, PIVCA was 2,225 and CA19 was 28. So whether in an ambiguous case of enhancement of the solid tumor in the liver cirrhosis, whether in need of SOL biopsy or we can take PIVCA2 as a marker and go ahead with the treatment. Need of any primary EVL prophylaxis, what are the treatment options, and with normal tumor markers and along with some elevated PIVCA, how to follow up and how frequently to follow up after initiation of therapy. So this is the approach of any patient with suspected SOL in the cirrhotic liver with AFP more than 20, or now in our case, it's less than 20. Any atypical vascular pattern on dynamic imaging, considered to do a biopsy. If it's diagnostic of HCC, go and treat as HCC. If it is non-diagnostic, then accordingly, according to the immunohistochemistry, you can go ahead. So this biopsy was done at Maharashtra itself with local place when it was advised, and it came to be moderately differentiated HCC with glypican-1 positive on IHC. And with the pattern on imaging was considered to be an infiltrated type of HCC with elevated ALP. So if we deal into PET, why not and when to do a PET? So based on the low FDG uptake in HCC is always because of there is high FDG6 phosphatase activity within the HCC, and which is then transported outside the cells. There's higher expression of P glycoprotein, and because of these reasons contribute to lower FDG accumulation in well-differentiated HCCs. Only in poor differentiated HCC we have high FDG uptake, and in well-differentiated HCC we have low FDG uptake. And in almost FDG uptake is observed in less than 40% of HCC patient. In our patient, there is mild uptake, but however, the characteristic imaging pattern was not suggestive of HCC, and biopsy was suggestive of HCC. So the final, role of PET-CT is complementary, specifically in patients with higher AFP to rule out metastasis. Suspected mets from liver, if their patient has any other pains, bone pains, cough, or any other complaints, you can go ahead with PET-CT to see for extrahepatic spread. And if it is a suspected non-primary liver lesion. So coming to the second question, should we do a primary banding for esophageal varices as we have grade 2 with RCS? So in our patient, we haven't done any patient as a non-bleeder, and previously as described by Dr. Anand. So we have not done any banding. We don't follow any primary EVL in such patients. So we have not done any banding and put on carvedilol. So coming to the final diagnosis is an infiltrative HCC with VP4 tumor thrombosis with extrahepatic spread in the form of lymph node involvement. Performance status was 0 with the PIVCA of 2225. So after discussing what are the treatment options, so this has been discussed with the patient. Coming to now, patient is coming into with an extrahepatic spread with a preserved liver function of performance status 1 to 2, and coming to we follow systemic treatment. Systemic treatment option has been explained, and following this, the patient were willing to afford immunotherapy. So we have taken as a first-line treatment of atezolizumab and bevacizumab after discussing with the patient. So the treatment started with atezolizumab 1200 mg and bevacizumab it's 600 mg. It's 10 mg per kg body weight, with first cycle from 27th May it has started, with the third cycle ending on 8th of July. The follow-up PET triphasic CT, there was interval reduction in FDG avidity. However, there's still significant FDG avid, which is there of 3.8. Also with it, there was even the FDG avidity has decreased even in the thrombus activity. Also, there is mild reduction in FDG avidity even in the lymph nodes. This is post 3 cycles. So the treatment was continued, and after 6 cycles of treatment, there was complete metabolic resolution and interval reduction in signs of complete hypoenhancing lesions in segment 4 of the liver. And also there's complete metabolic resolution in the tumor thrombus, and it's a bland thrombus currently. However, the lymph nodes, there's no significant change in metabolic activity, and there's still a low-grade FDG avidity is still persistent. But the overall, the size of the lymph node has come down considerably from 1.7 centimeter to 8 mm. So this is the AFP margin, which is from 5.8, it has come to 2.58, and over duration, it has again come to 4.2. And this is the PIVCA. Initial was 2225, which has come gradually, and now it's stable at 52. So post 6 cycles, patient now presents with new symptoms, such as hoarseness of voice, which has been previously told by Dr. Anand. That is common feature now currently with the immune checkpoint inhibitors. There's decreased voice intensity, fatigue. But however, if there's a new significant problem, which is a dyspnea on exertion, which was not there previously. So at that time, the previous saturation was 99 before the start of therapy. But when the patient presented with dyspnea on exertion, when check the saturation, it was 95%. The 2D echo ECG was normal. Patient was not orthopenic, and it was only complaining of difficulty in exertion more on climbing stairs, and is not unable to climb even first floor. Before he was used to climb for 3 floors. Now it's difficult for him to even climb from 1 to 1.5 floor. So what are the possibilities? So we have searched for the possibilities. Then we have compared the 2 PET scans previously done. So when we see the PET scans, this is the first PET scan, this is the later PET scan. The new changes which are seen on the lung fields. These are honeycombing appearances which are seen at the periphery. So these are subpleural honeycombing and reticulations which are predominantly in the lower lobes. And this is the same, almost the same lung cuts, which you can see both the bronchus. And this is suggestive of ILD. So after this features, then we have done a 6-minute walking test, which was already showed a significant difference. The patient initially had baseline of 95% saturation. After the test was significant reduction to 90% saturation. And the dyspnea scale has increased from 0 to 3, and distance walks, and the distance walked was only 288 meters for 6 minutes. And autoimmune markers were sent and found to have ANA-IF was 2 positive. Other markers for all the ILD workup was negative. So we search for other search for the immune-related adverse event. This is a good article which has been published in the Nature Reviews, that the immune checkpoint inhibitors can produce various immune-related adverse effects from the brain to the body, from the muscle to the nerve at all. So interstitial lung disease is one of the adverse effects which can be seen with immune checkpoint inhibitors. But in all the published data, this is the Indian data, and this is the initial IM-Brave data. When we have seen that the lung involvement has not been put as one of the most common side effect or as the rare side effect, and not been published here. So even this is IM-Brave 150 data, which showed that any grade more than 10% in the group, the lung parameters or a decrease in saturation or ILD features has not been mentioned anywhere. But however, because considering this ILD changes post-treatment, we have stopped Ativeva because there's significant change in the lung parameters, especially with the 6-minute walking test and decreased saturation. So consider it is to be grade 3 or grade 4 adverse event. We have started him on steroids, 0.5 mg per kg body weight for 2 weeks and followed by tapered dose. Then it was explained to him that the other option is TKA as a bridge and was planned. But lenvatinib was started after 2 weeks, but he could not tolerate and stopped after 1 week of the treatment. He was having significant abdominal symptoms and he was having significant loose stools. So lenvatinib was stopped after 1 week after the initiation, but he was continued on steroids alone for 1 month. 1 month post steroids, the dyspnea and exertion was improved, fatigue improved, there was improvement in the voice quality and also the voice strength. And the 6-minute walking test, initially distance was 286, now he was able to walk for 350 meters. And the saturation was normal at baseline, 99%, and improved to, and it has come down to 96% after 6-minute walking test. So this was the post-steroid effect. This is the post-steroid CT which was been done. There is mild decrease in the overall reticulations and overall honeycombing, as you can see in the periphery. Still persistent, but still comparatively decreased. Now what to do? So patient is not tolerating TKI. Patient has developing ILD features, but has significantly improved. So after further discussing with the attenders and with the patient, if they're now he is comfortable, so he wanted to continue with immune checkpoint inhibitor. So further, with the informed consent, he will continue with atezolizumab, bevacizumab, and post 9 cycles as on 9th December. So this was initially with the risk of imaging because of the radiation. First, initially we have done an MRI. So MRI showing that there was non-viable lesion because there was no diffusion restriction. Complete thrombosis of left portal vein branches. There's no enhancement or even on post-contrast phase. So almost all the lesion is currently at present. There's no diffuse restriction and complete response in the tumor itself. But what about the lymph nodes? There were lymph nodes which are around 1 centimeter, less than 1 centimeter lesions which are there. But there was no obvious necrosis within. There was no diffusion restriction. So whether to stop immune checkpoint inhibitor and go plan for transplant or not. So we had to take the decision and go for the PET-CT to see if there any FDG uptake. But unfortunately, there was still mild FDG uptake. It has decreased considerably, but it is not completely absent. But there's still uptake in the lymph nodes which is present. However, in the liver and in the lymph node and in the portal vein thrombosis, there's complete loss of activity. There's no FDG activity. However, the lymph nodes still have mild amount of activity, and hence patient is currently on atezolizumab, bevacizumab, still going on. But there are no further worsening of ILD features. There is no further worsening of dyspnea and exertion. So currently patient is under follow-up. So current status, there good disease control rate. There was bland PVTT which has been achieved. Very mild FDG uptake is still persistent in the lymph node. ILD is controlled. Patient is TKI intolerant. Whether to, even after the extrahepatic spread, whether to after complete metabolic resolution to consider LT or not is further under discussion with that patient. So the take-home points: biopsy in radiological ambiguity, almost complete response possible with combination of AT plus bevacizumab. Varicose ligation in high-risk cases not compulsory, needs tailored approach. Rare side effects with ICI is possible. Always to look for change in the presenting complaints and act fast. Steroids for possible side effects. And imaging how frequent in metastatic disease. Always to consider radiation risk versus disease assessment, benefit, and take a call. Thank you. Happy to take any questions.
Santan, can I ask a question?
Sir.
Santan, can I ask?
Yes, sir. Yes, sir.
This patient, what are the initial AFP normal, no?
Yes, sir.
And PUCA was
2200, sir.
Hello?
Sir, AFP is 5.8 and PUCA is 2225, sir.
Okay. And how was ILD proven?
ILD is based on the imaging, sir.
Okay, imaging.
Imaging.
Should we
previously this was the lung field, this is not there in the lower lobes.
Okay.
These are the new things which are found.
Interesting question. The complete response, there the definition of response actually has been given by there's one study by Dr. Kudo. How to identify a clinical response in this patient. There should be no active liver or extrahepatic lesions.
Yes.
And persistently normal AFP and PUCA, both should be normal. How much is the
AFP
PUCA now?
has come to normal within after 3 cycles only. It's only the uptake which is there, sir. This is a PUCA from 2000 has come to 35.
So is this is it possible to have pseudo progression in lymph nodes? I'm not aware of that.
The uptake is not increasing. It's the size also has decreased. It's only the mild uptake which is there. Whether to take risk and go for transplant or wait for few more cycles.
You can do a biopsy of that lesion. Where are the lymph
It's
nodes
less than
now?
1 centimeter, sir.
And the location?
Location is para-aortic. You can see.
Para-aortic.
Pre and
US
para-aortic.
guided, very difficult to reach there.
Yeah, and 8
If
mm
possible, if we can somehow do one biopsy, that would be.
Because the uptake
Or
is 2.5, it has considerably decreased now.
Diag करके we can check whether it is inactive, then we can take for transplant.
Correct.
Interesting. ILD actually is very less commonly thought of
Correct,
patients
sir.
in
That's why. So once he
multiple
started
sclerosis.
complaining, then review of the scans showed this ILD.
Okay. Yes. Thank you, Santosh.
So the Shantan, whether the steroids were continued or stopped?
No, I have stopped after 1 month, sir. Because after his improvement, I have stopped currently.
Okay.
But he is on inhalational steroids, sir.
Okay, he's doing well. He doesn't have Disney and all.
Yeah. On inhalational steroids, he's doing well. Oral steroids, systemic steroids have stopped.
Right. Okay.
Dr. Shantan, Dr. Santosh this side.
Hi,
I
sir.
think better we do a sampling and plan for transplant. That
Understood,
would give
sir.
him a time-limited treatment and curating. Especially
Yeah.
laparoscopy and biopsy we can do. The second option is take for liver transplant and do lymphadenectomy also. So
Correct.
in
But
this case,
currently, the other issue is the patient is not having a viable donor currently. They are searching for donor.
Okay.
So just giving him a chance of a lab donor that without a donor is difficult. So they're still searching for donor. So I asked them to search for donor and follow up now. So the plan is to go for US biopsy, but the 8 mm size is difficult for them to approach.
No, interop, I'm telling.
Yeah,
Interop.
understood.
You did complete
You're saying
clearance
the
of that
frozen
lymph
section
node
biopsy,
station,
right?
lymphadenectomy.
Correct.
Yes. The other thing is, we see this ILD related to immunotherapy in other malignancies also.
Correct.
What we do is, whenever we re-challenge, in that scenario, we give tocilizumab along with it. So there is ample data.
I think that is for severe. That is for severe cases, right?
Yes, our patient is grade 3, developed hypoxia on exertion and all. So especially grade 3 and grade 4, a combination in tocilizumab and re-challenge is a valid strategy that we followed in few of our cases.
Okay.
So anyway, very interesting case. So have we seen any cortisol? We have seen, cortisol?
No, cortisol I haven't checked.
Okay. One other common side effect we see is adrenal insufficiency with these immunotherapy agents. So some amount of fatigue, weakness and all. So some adrenal insufficiency also we sometimes see.
So
Just a thought
normally we
process.
do if they have some sort of, say if the patient having a normal tensive, now he has become hypotensive or lower blood map compared with the original map, or else if there is hyponatremia or hyperkalemia.
Okay. Right. Okay. Thank you. Nice case.
Anyone has any question? If there is no question, we will conclude today's session. Thank you everyone for joining. Thank you all the speakers and thank you all the delegates for joining us for such a wonderful webinar. Thank you. Thank you everyone. Have a good night.
Thank you. Thank you very much.
Good night.
Technical team, please close the meeting.